So this course is everything to do with very interesting topic of management of subluxated IOLs or back complexes, tips and tricks. So let us have it a very open, interactive section so that we can all exchange ideas as to what we think is possible. So we'll start with the first part of it. So I always say, don't challenge your limits. Keep challenging them as the limits keep changing and you start pushing it. So you may have weak zonules, there may be traumatic, there may be vitreous prolapse, arup. There may be pseudo exfoliation, and we tend to fall. But I'll show you multiple cases, and as I mentioned, let it be a very open interaction. So, refitting IOLs and back complexes. What's new next year? Every year, when there is a new year coming, we decide that something else we'll do this year. So, some people say, let's lose weight, let's get fit, let's enjoy life, let's have a life balance, etc., etc., etc. So, as you get more and more experience, see, I have also not been doing very complex cases, but then you attend more conferences and you start doing more and more complex cases and attacking more and more scenarios. Now, this is a very interesting case where the lens had actually dropped into the vitreous. And the patient presented to me, and this surgery was done by me only about 25 years back. When we did a B scan, yes, we know that something is there sitting in the eye. On indirect, we can see that an IOL is there. We did a specular, no history of trauma. Now, what are your options? Now, patient did not have any papers because operated 25 years back. So you have to be ready with lots of options because 25 years back, what IOL was used and what IOL is being used are all different. So you have to explant the IOL by cutting it or refitting it, or you can put an AC IOL, which nobody does anymore. You can do a glued IOL, you can do a scleral fixated IOL, or you can do a posterior iris claw. Correct? These are your options today in today's science. So what did we do? This is very interesting. Of course, we blocked the patient. We decided to support. So we made a port. We put in a trocar after the measurement, and when you move the eye, you can see something moving. Okay. So question here is now what? Because you don't know what is inside. You know that there is an IOL, and the patient was happy for so many years, and suddenly appears that now he can't see. When you move the eye extremely, you can see that yes, there is something there. Went ahead and did a trocar so that we got the support. And then, of course, I planned to do a glued IOL. So my original idea was remove whatever was inside and glue another IOL. So then you start making your flaps, do your measurements, do all those ports. And then I started making two side ports and started doing a vitrectomy. To my luck, as soon as I started the vitrectomy, the lens came up. Now, some of you may not have been born to know the design of this lens because I don't know how many of you know this. To you, it looks like a normal foldable three-piece IOL, right? Just for your information, this is a dialing hole. So this optic is 6.5 millimeter, 0.1. It has got four dialing holes. So what you see, these are four dialing holes. So purane jamane mein, what we used to do, put a Sinsky hook into this dialing hole and put the lens inside the bag with that dialing hole. This was a technique 25, 30 years back. Okay. But to you inform you, these are non-foldable IOLs. So they are solid PMMA with PMMA haptics. Okay. So now these IOLs cannot be cut. Normally, my strategy here was cut this IOL and put in a three piece and glue a new IOL, right? Very simple, no confusion there. So now I've got this lens, and these are not modified J haptics. If you realize, this haptic is huge. So these are J haptics, they are not modified J. Then came C, and then came modified C. So over time, there has been an evolution in design of IOLs as well as haptics. Okay. So here I'm bringing the lens entirely out, making sure that there is no vitreous traction. Go around and do your vitrectomy and bring the whole IOL in the front. So this is what I'm doing. Now the question here is, the whole IOL is in the front, but if you look at the orientation of the haptic is like this, and the other orientation of the haptic is like this. And these are forward angulation 10 degree. So I cannot glue this IOL in this direction because it's 10 degree forward. So it'll be touching my endothelium. So I decided to flip this IOL in the AC itself. So I have an iris repositor and a Sinskey hook. The whole IOL is in the anterior chamber. This is, as I said, non-foldable 6.5 millimeter optic and this. So now I've flipped it to get posterior angulation, 1 point, and get the right angulation or the right direction of the haptic, 2nd point, to be able to glue it, right? So when I'm able to glue it, this haptic will come out like this and the other haptic will come out like this. So now go ahead, make your ports, go ahead. Now it's difficult to externalize these haptics because of the design of the haptic. They are J haptics. They are not modified J, which are a little shorter. If you see the 3-piece Alcon, they are shorter in length as far as the J haptics are concerned. So here I had to go far ahead to be able to get the tip. It's very, very important to be able to hold the tip. And now you can see that I'm going ahead, holding the tip and bringing it out. And you can see a large haptic has got externalized because this was an old design IOL. Same thing is done on the other side, and then go ahead and glue. So the beauty here was no IOL calculation. I could refix the same IOL which had got dislocated into the anterior vitreous, and the patient is doing very well and the patient is very happy. So through a 2.75 incisions, I could manage the whole case. So this is quite easy, understandable for you that it's good to be able to refit the same IOL. So refitting is better than explanting. Older designs which have J design are a little difficult, but they can be managed. And of course, it's a good technique with a stable IOL. Now there's another thing that happened. Now you can see this. In olden times, we used to do an iridectomy. Nowadays, we don't do an iridectomy. So you can see that it's a subluxated IOL, and there is again a modified or a rather J. I'm supporting this. Samita, you can come on stage. So you can see now here again the question was what I thought is we will try to refit the same IOL. It had subluxated. You can't leave it in the sulcus. If you leave it in the sulcus, it's going to go back in. So this is one thing you must remember, that now I have a same design IOL. I'm going ahead and making now, this pupil won't dilate. Remember one thing, if the pupil doesn't dilate, you can't use a ring. So you can't use a Behex ring or you can't use a Melugan ring because it's not going to give you enough exposure to know what's happening in the 4 sulci. So here I'm going to use iris hooks and then get adequate exposure. Now this lens design is the same as what I had shown you. So you can see it's subluxated. There's a lot of vitreous all around. I'm doing vitrectomy to free the lens of all the adhesions around. I put 4 hooks to get adequate exposure. Once I've done that, I brought the same lens in the front and then refitted it. So here again, same design, same technique. Go ahead. This is a J haptic design. Do your vitrectomy, free the IOL completely all around. Once you've done that, go ahead and externalize the haptics and fit it into the glue technique of what Dr. Amar Agarwal has told us and taught us over the number of years. And this works extremely well. So this is another way of handling the same case. Now there's one more way of handling this. Now again, this is all that the pupil dilates. You can see an IOL which is subluxated. Don't use a ring because that's not going to give you more than a 6.57 exposure. So again here, it's very important as far as I'm concerned to make sure that we make the 4 marks to put the haptics. If you don't make these marks, you may get a little odd shape of the pupil and it may interfere. So if you want a perfect square or a perfect rectangle, it's very important that we go ahead and mark it. Once you marked it, go ahead and put your haptics. Now the question here is, this lens has subluxated. You can see it's a 3-piece design. And we know that 3-piece designs are the best lenses to be put in the sulcus. So now I'm centering this lens. But you can't leave it there because if you leave it, it's going to subluxate again. No doubt about it, right? So you can use this as a corneal marker. Mark the center, right? You can go ahead and mark the center and then put in viscoelastic. But the question here is, how are we going to prevent this lens from decentering again? So I make another side port and then I go ahead and do a little small vitrectomy. So in olden Jamana, when we used to put the lenses in the sulcus or in the bag, the anterior posterior capsule actually fuses and becomes one. So here what I'm doing is, in that fusion of the back complex, I'm making an opening. And I'm going to do an optic capture of this IOL into that opening. It's very important to create an optic capture. You need an adequate opening. What is adequate? Don't forget the size of the optic is 6. So you need it to be at least 5. You can't do a 3.5 and then want to do an optic capture, because that's not going to happen. It's not going to work. So here I'm making a small opening and then I'm attempting to make an optic capture. Okay, so I've done the opening and I'm going ahead and doing the inferior optic beneath the fused anterior posterior capsule and then the superior part. Now I'm not able to go ahead, so I decide that this opening is not adequate. So if you want to do an optic capture of a 6 millimeter optic, you need a 5 or a 4.5 millimeter opening. So I go in again and enlarge that opening, and then I am able to successfully do an optic capture, and this lens will never ever decenter. So this is one more way of fixating the same lens. Now, when you fixate the same lens, all your calculation headaches are gone, because it's very easy that the patient was very happy before. Once you fixated it, the patient is going to do very well. One more case operated by me now almost 15-20 years back. Some of you will not know anything about this. A 733 or a 737. This lens was made by a company called Acritech. Acritech got bought by Zeiss, and now they give multifocal IOLs. So this was an excellent 3,000 rupee bifocal IOL with the highest PCO rate, because it never had a square edge. So it always used to give a high PCO rate. But now this patient comes with a YAG opening. Original power of the sticker is there and the IOL is not in place. Samresh, you can join us on stage. So this is how the patient comes to you in the OPD. You can see a subluxated multifocal IOL. So when you see if you get a PCO in a multifocal IOL, if a doctor dilates and sends to you for YAG capsulotomy, please don't go ahead and just do a YAG in a multifocal IOL. Because when the pupil comes down, you will realize the lens is decentered. So it's very important that when you want to do a YAG capsulotomy in a multifocal IOL, see the patient undilated. See whether the pupil center and the ring center is matching. Then you can go ahead and do a YAG. But now this patient came to me and allergic to Tropicacil Plus. So all that the pupil really dilates is this. So you can see that the lens is subluxated. Pupil doesn't dilate more than this. Then what are you going to do? And patient said, I had a multifocal IOL. The other eye is 737. This eye was 733. It was designed as 30-70 for near and distance. And this is all the pupil dilates. So now what are we going to do? So you can see a nice YAG capsulotomy and a subluxated multifocal IOL. So here under topical anesthesia, we are going to go ahead and do some surgery. So I'm making a small nick and we put intracameral epitrate, which is a diluted form of adrenaline. So you can see now the pupil dilates. So you're lucky. Sometimes epitrate does not work. If it doesn't work, then we have other options. But here you can see the pupil slowly dilate. 2 haptics appear. The optic was seen and the YAG capsulotomy is also seen. Don't forget, patient wants multifocality. Okay. So this haptic that you are seeing here is fused between the anterior posterior capsule. This haptic is sitting in the sulcus. And this is your disc or the optic which is floating. I've had 2 such patients which auto-dislocated. So that's called auto-dislocation of an IOL. It happens in this design over the number of years. Okay, go ahead and put Kenacort, which is to stain the vitreous. Go ahead and do your vitrectomy and you can see the whole disc floating around. So now we have to explant this disc. Remember, to cut, you need to hold. So you need to use a micro grasping forceps. Go ahead and cut and use your incision itself as a fulcrum to dial the optic out. So you don't need to cut all the way halfway and then remove one half IOL and then remove the other half optic. So what I'm showing here is just cut 3 millimeter because it's a 6 millimeter. Hold one edge. You use your incision as a fulcrum and rotate the disc out. You can see that I'm rotating the disc out and the disc just comes out and it's fine. Now the question is what to do next, because the patient said, I want multifocal. Go ahead, remove that haptic which was there sitting in the sulcus and make sure that all the iridocapsular adhesions, if present, are released. Go ahead and do your vitrectomy, make sure everything is good. Now in this case, I have only one option, and that's a Technis multifocal IOL, which is a 3-piece design. Okay, but if you're putting a multifocal IOL in the eye, and you have an anterior posterior capsule which is fused with a YAG opening, the only way we can make sure again here is that do not leave it in the sulcus. You have to capture it in that opening, and that opening is adequate. So here I'm going ahead and then putting the haptic in the sulcus, going ahead and putting the optic. Once I put the optic, now I'm going to capture the optic in the opening which was originally created for the yak capsulotomy. So you can see that inferiorly the optic is covered. Now superiorly the optic is covered. The IOL is sitting beautifully in the sulcus. Now this design will never ever dislocate or subluxate because it's very well captured. These bags behave extremely well and they do very, very well. So this is one more way of doing the design as far as this is concerned. Let's go and show you one more case. Now this is a single piece IOL. Okay. Now we know that single piece IOLs are not good for sulcus, right? We want a 3-piece IOL. So what are your options here? You can see an opening here, right, which is a small opening, and it's a subluxated IOL. Now here I am actually explanting. Now there are various ways. Now there are hydrophilic and hydrophobic. The hydrophobic ones are quite difficult to explain, but the hydrophilic ones are quite easy because they don't stick to your capsule. Here this is an old design, single piece, non-foldable IOL which had subluxated. So I don't want to leave the same in the sulcus. So I'm slowly releasing all the adhesions from all around, bringing it in the AC, explanted this IOL, and then I need to put in another IOL, obviously. So here I go ahead and put a 3-piece IOL. And then this 3-piece IOL again should not subluxate. So I make that opening which was there, enlarge it, and then optic capture it. So there are various ways of handling the situation. These bags are very, very strong. You really don't need to worry, and this can be held quite well. Once you go ahead and do your vitrectomy, we just optic capture the same IOL and put it in the sulcus where it was. This is the last case that I'm going to show. Patient came to me like this. So the take home message here is, please listen to your patient. He says, when I sleep and lie down, I can see better, but when I sit up, I can't see well. So how is that possible, right? So you can see that this is what you are seeing here is a haptic and an endocapsular ring, and this is how it was. So when he lies down, the whole back complex moves up, and when he looks at the ceiling, he can actually see the ceiling. But when he sits, the back complex goes down and he can't see. So there is an endocapsular ring, there is a single piece IOL, and the whole bag has subluxated. So what are your options here? You can see this is a slit lamp video, and when the patient moves, the whole bag is moving, right? Now what are our options here, and what can we really do? Here we have 2-3 options. Remove this whole back complex and do another glued. You can even do a posterior iris fixation, whatever you want, but I went ahead and did something else. So we'll show you what I did. So now the patient is lying down, patient is blocked, we are putting a trocar, and if you see now, to you this whole complex appears quite well centered. But when the patient sits, the whole back complex was going down. So here we are going ahead and putting our 2 Hoffman's pocket, reverse Hoffman. Once we have done this, we go ahead. It's very important that here I tried to fixate this bag back. It's important to use Gore-Tex, but I didn't have Gore-Tex, so I use Ninoprolene. Okay, one important take-home message is always fixate the same point away from the optic haptic junction. So here I have a needle going from this part of the sclera below the endocapsular ring, below the haptic, and coming out, and I'll pass a Ninoprolene. The second loop will go above, but this junction, so you have to remember this distance from the optic haptic junction, and that's the only way you'll be able to center this IOL. So here I'm going ahead and passing this railroad technique. Once I've done that, I'm going to go ahead and pass the other one from above the optic haptic junction. And this is the other one, that's needle, and that will go beneath the iris, and the endocapsular ring and the haptic is below. And now I'm railrolling the other side, okay, and got it. So I've got it looped around, and the same thing I'm going to do on the other side. So you can see I'm going to do the same thing on the other side. So very important to remember that distance from the haptic optic junction where you need to hold the back complex. So here I'm going ahead. Now you can see the whole endocapsular ring and the haptic above your needle, and the other pass will be below the iris and above the endocapsular ring and the haptic. Once I've done that, we just tighten the 2 sides, and this holds on quite well. I understand that Ninoprolene may not be as good as Gore-Tex, but when you tighten both the sides, you can see that the whole back complex is centered well and tightened well. I think I won't show, and this is day one post-op. Patient did well and patient is happy. Thank